All right, everyone, let's take off for our second speaker of the morning. We're going to be hearing from Dr. Peng. Let me see if I can find Dr. Peng here. Um, Dr. Peng is a neurotologist. He works at the House Ear Clinic. He speaks several languages, Mandarin and Spanish. His education, his medical school was UC San Diego. Internship was UCLA Medical Center. Residency, UCLA Medical Center. Fellowship at UCLA, David Geffen School of Medicine, and his board certifications are in neurotology. I had the opportunity to work with Dr. Peng for a number of years and found him to be very insightful, very intelligent, good with children, just an overall good doctor. Highly recommend him. He's going to be speaking to us today about something that we don't always get a lot of input on, acoustic neuromas. And I think it's going to be a very interesting presentation. So welcome, Dr. Peng.
Thanks,
And
Alan.
you want to take a break after the first hour, is that right?
Sure. I have just a slide that's sort of a placeholder, and then we can
Okay,
take some questions then in case any questions come up for the first
okay.
half.
All right. Now hold your questions in until the first end of the first half, and then we'll take questions then.
Okay.
Okay, I'm going to back out of here and let you take over.
All right. Thanks, Alan, for having me. It's a great pleasure and honor to be speaking today again. And Alan tasked me with talking about acoustic neuromas. So I'm going to be going over various aspects from the presentation, all the way to treatment and rehabilitation afterwards. As Alan said, I'm a neurologist at the House Ear Clinic and House Institute Foundation, based in Los Angeles, California. I have one disclosure, and this has no relevance to the contents of my talk. What I'm going to be going over is first talking about acoustic neuromas. Many of you know that acoustic neuromas are now termed vestibular schwannomas. I think there was a change toward calling it more a vestibular schwannoma rather than acoustic neuroma, probably about 15 years or so ago. And the reason for that is because these tumors come from the vestibular nerves. They rarely come from the cochlear nerve. So there was a shift at that point to basically start calling them more vestibular schwannomas. But as all of you know too, acoustic neuroma is still a term that we use very frequently. Patients know the terminology arguably better than vestibular schwannoma, and various organizations, such as the Acoustic Neuroma Association, have the term acoustic neuroma in the name. We're going to be going over again the presentation, how we diagnose it, how we treat these tumors, and then finally the audiologic rehabilitation from the physician's perspective. I know that many in the audience have a lot more experience than I do with regards to rehabilitation, but I'll give you sort of the physician's take on how we see things after patients have undergone treatment for acoustic neuromas or vestibular schwannomas. So we talked about how it's a benign neoplasm of a cranial nerve, so it's non-cancerous. It can arise from either the inferior vestibular nerve or the superior vestibular nerve. And the eighth cranial nerve has, again, a third component, which is the cochlear nerve. Rarely do the vestibular schwannomas that we see come from the cochlear nerve. Usually it's coming from one of the vestibular nerves. That's actually something that we can't tell until we're doing surgery. Meaning on scans, occasionally we can try to divine which nerve fiber it's coming from, but most of the time we can't really tell. These are slow-growing tumors, so they've typically been in place for many years by the time they're symptomatic and diagnosed. And once again, the term acoustic neuromas is still very commonly used. I'll be talking in a little bit about an MRI scan and the different types of scans that we do, but this is a tumor here on the right side of the patient's body. By convention, the left side of the MRI scan picture is the right side of the patient's body, and vice versa. And so this patient has a right-sided vestibular schwannoma, and you can see it's white, it's bright after administration of intravenous contrast with the MRI scan. So what are the cranial nerves? This may be a review for some of you. The cranial nerves are paired nerves. We have one on each side for a total of 12, and they each go to different end organs, pretty much mostly in the head, neck, throat, face, in the upper part, before the spinal cord takes over and controls the rest of our body from neck down. And so, of course, the vestibulocochlear nerve, which here is labeled in pink, is one of the paired cranial nerves. So we have one vestibulocochlear nerve on each side. And again, on each side, then we have an inferior vestibular nerve, a superior vestibular nerve, and a cochlear nerve, all traveling within that pink bundle. Adjacent to the vestibulocochlear nerve is the facial nerve, which is cranial nerve number 7. And then so 7 and 8 are next to each other, and they travel in the internal auditory canal, which is a little pipe basically leading to the exit of the skull. The facial nerve then takes a turn at the end of the internal auditory canal, whereas the vestibulocochlear nerve goes straight into the vestibule, the semicircular canals, and the cochlea. And these cranial nerves all come from the brain stem, an area of the brain called the brain stem, and so that's basically the part of the brain between the cerebrum and cerebellum, and all the way down to the spinal cord. That intermediate section is called the brain stem.
Dr. Peng, sorry to interrupt, but do you have slides?
Oh my gosh, yes. Sorry. Is that better?
There it is. Thank you.
Thank you. I'm going to show this graphic. Thanks, Stevens. I totally didn't realize I wasn't sharing. This is the graphic that I was trying to show earlier of the enhancing tumor, the one that's bright after people get IV contrast on an MRI scan. And this is the diagram of the paired cranial nerves. So the pink nerve here is the vestibulocochlear nerve, and the green nerve is the facial nerve. So where do these vestibular schwannomas arise? They arise in the cerebellopontine angle, and then so the cerebellum is the hindbrain, and right next to it is the pons, which is the middle portion of the brainstem. And the tumors basically grow from that area because that's the area where the vestibulocochlear nerve lives. And once again, the seventh cranial nerve, or the facial nerve, is also right in that area. So these tumors grow right next to, often on top of or adjacent to, the facial nerve. What are the different types of tumors that we find in this area? The vast majority are vestibular schwannomas, and then so those would be tumors that again arise here. But sometimes we actually get other pathologies. Meningioma would be the next most common one. People can get arachnoid cysts, which are fluid-filled, CSF, cerebrospinal fluid filled, basically balls, cysts located right in that area. They're epidermoid tumors, which are basically skin cells that are in the wrong location. So instead of being on the outside of our body, they're located inside, right next to the brain. And then finally, occasionally patients can have metastases. Breast cancer, kidney cancer, renal cell carcinoma are two of the more common ones that can metastasize basically to next to the brain. So vestibular schwannomas weren't even really a thing. Nobody knew about them until the late 1700s. And Dr. Sandefort from the Netherlands wrote a paper, and the translation of the Latin is here, a certain hard body attached to the auditory nerve. And he was describing what he found on autopsy of a patient with unilateral hearing loss, unilateral deafness. And that's the first known description of a vestibular schwannoma. Fast forward 50 or 60 years, and Sir Charles Bell, who is well known for Bell's palsy, among other things, basically described a patient with a loss of facial sensation, and that's the fifth cranial nerve. And the patient also had hearing loss, ataxia, so difficulty with walking and coordination, and dysarthria. And this patient was found on autopsy to have a vestibular schwannoma. And he determined that the cause of death was likely respiratory failure because the brainstem was getting excessively compressed, squashed by the vestibular schwannoma. In 1829, Dr. Cuvelier from France similarly described a patient with the symptoms that I've listed on the slide. And he also noted that the patient had a large tumor adjacent to the brainstem. And then so over this period of time, people were basically starting to realize more and more that this is a tumor that's a distinct entity in and of itself. Through the rest of the 1800s, there was more awareness again about the existence of this tumor and the diagnosis of the tumor. And then at some point in the late 1800s, patients basically started undergoing surgery for this. Unfortunately, that was in the era of no aseptic techniques, so things weren't sterile or clean, and there was a high mortality associated with vestibular schwannomas. I'll be going over the history of surgery for vestibular schwannomas when we start talking about the treatment. So let's talk a little bit about the genetics. These tumors typically have a mutation somewhere along the neurofibromatosis type 2 gene, which is on chromosome 22. The protein that this gene ordinarily is supposed to code for or produce is called merlin. And in patients with unilateral or what we call sporadic vestibular schwannomas, so it's not hereditary and they don't have the condition called NF2 or neurofibromatosis type 2, that gene is typically inactivated in the tumor cells. And so because that gene is inactivated in just those cells will start forming these tumors and they'll start dividing. One cell becomes two, etc. And they'll basically form a little ball of tumor cells. Now, some patients have NF2. And as many of you know, NF2 is a genetic condition which can happen one of two ways. Either it's an inherited mutation, so a patient gets it from one of their parents, or it's a de novo mutation where nobody in their family has previously had it, but when their genes are being formed, they basically have a new gene mutation in their system. And so those patients have bilateral vestibular schwannomas, which we'll talk about also. When patients present with a vestibular schwannoma, the most common age of diagnosis is about 50 to 60 years, depending on whom you ask. But we know that it can occur in a wide variety of ranges. Sometimes we diagnose it in pediatric patients. Sometimes we're diagnosing it when patients are hitting 70 or 80. The earlier it's diagnosed, the more likely it is to be a more aggressive type of tumor, or more likely to be related to neurofibromatosis type 2. The growth rate of vestibular schwannomas is about a half a millimeter to 1 millimeter per year. So as you can imagine, by the time it gets to maybe 10 millimeters or 1 centimeter, the tumor has likely been there already for many years. A majority of the tumors grow after diagnosis, but um, that also means that some tumors actually don't grow significantly after they're diagnosed. And this is a paper that came out many years ago. I think it was about a couple of decades now, that basically talks about the natural history of vestibular schwannomas, and it's one that is cited often. So we're going to talk a little bit about the presentation of the vestibular schwannomas. The most common presenting symptom is asymmetric hearing loss. And as we know, this hearing loss is typically sensory neural. If there's a conductive hearing loss, of course, all bets are off. Sure, I suppose a vestibular schwannoma patient could have some reason to have a conductive hearing loss also. But as you can imagine, with the tumor pressing on the cochlear nerve, it's a sensory neural hearing loss. Dizziness is a symptom that's not as commonly reported by patients when they're first coming in. If we're asking them, patients will often say they're dizzy or they've had dizziness episodes. But rarely does a patient come in and say they're dizzy and we get a scan and it shows a vestibular schwannoma. And then finally, facial numbness and paresthesias or tingling of the face are a potential presenting symptom. I've listed a couple of rare symptoms, which we'll go over in the subsequent slides. And hydrocephalus this is what hydrocephalus would look like on a scan. It's basically water on the brain. And sometimes this can happen if the tumor is quite large. The facial nerve is actually pretty robust. So most patients presenting with vestibular schwannomas actually have normal facial function. Talking first about the first presenting symptom that I mentioned, hearing loss. Sudden hearing loss is actually one of the symptoms that patients with vestibular schwannomas present with. Depending on which paper you're reading, about 70 to 20%, about 7 to 20% of vestibular patients will present with a sudden hearing loss, an idiopathic sudden sensory hearing loss as their presenting symptom. Once we figure out that it's a tumor in those patients, of course, we can't call it idiopathic anymore because then we know the reason. But if we're just looking at the patients coming into our clinics with sudden hearing loss, a fair percentage of them will actually have a vestibular schwannoma. Depending on whom you ask, if you look at all sudden hearing loss patients, up to 1% will have vestibular schwannoma. So from an ENT perspective, it's imperative for us to order an MRI scan with patients with either sudden hearing loss or a significantly asymmetric sensory hearing loss at presentation, because then we can be screening for these tumors. When patients are coming to us with sudden hearing loss, we often don't have an MRI scan right from the get-go. So we treat patients for sudden hearing loss the way we usually treat them. So we use oral corticosteroids, such as prednisone. We use intratympanic corticosteroids, and then we'll even consider hyperbaric oxygen therapy. At some time along the treatment course, we'll be talking to the patients about getting an MRI scan and basically looking for a tumor. But initially, patients are coming to our clinic just initially for the treatment of the hearing loss that's present. When we have a sudden hearing loss patient, ideally oral corticosteroids should be started as soon as possible. And then one of the main regimens that we use at our clinic, and it's pretty common across the country too, is prednisone 60 milligrams for several days, for many days, followed by a taper. And the exact length of the prednisone taper and the style of the taper, how fast the taper is dependent on the physician. If oral corticosteroids aren't working, or sometimes in addition to oral corticosteroids, we'll be recommending intratympanic steroids. And intratympanic steroids means we're actually injecting a liquid steroid into the tympanic membrane. So the most common medication that we use in our clinic is dexamethasone in solution form, and we have it specially compounded to a concentration of 24 milligrams per milliliter. Depending on whom you ask, other medications can also be used. Methylprednisolone or Kenalog, which is triamcinolone, can also be used, and those are also injected into the eardrum. And again, it's highly doctor dependent, but typically we'll be recommending either 3 or 4 injections over 2, 3, 4 weeks. And there's surprisingly no standardized protocol. I think all of us have a feel for what we think works for the patients that we see, and that dictates the treatment course. Depending on whom you ask, which paper you read, about 30 to 60% of all patients will have some recovery of their sudden sensorineural hearing loss. And we realize, of course, that means that probably 40%, if not more, of patients won't have recovery. So sudden hearing loss is unfortunately can be an uphill battle for the patient and for the physician. Hyperbaric oxygen is one of the treatments that also helps improve hearing in patients with sudden sensorineural hearing loss. And typically, we're recommending 10 to 20 treatments. This is done at a hyperbaric oxygen center. There are many centers around town. For example, if you have a patient with sudden hearing loss and you're trying to find a center for them, if you just do a quick online search, you'll see that there are many, many centers in most major metropolitan areas. And the pressure that is typically recommended is about 2 to 2.5 ATAs. 2 ATAs is double the normal atmospheric pressure, and that corresponds to about the equivalent of being 10 meters underwater. And each of these sessions, each of these 10 to 20 sessions, lasts about 60 to 90 minutes. This is a photo of a less common configuration, at least based on what patients tell me and what I've read and seen, of a hyperbaric oxygen chamber where you have multiple patients sitting inside a large chamber and they're pressurizing the entire chamber for all the patients. And this might be one of the more traditional chambers, and they come in all different shapes and sizes, and clear and not clear. The basically another chamber where patients will, in this case, lie down and undergo their therapy, and this fits one patient. During the course of treatment, at some point we're recommending an MRI scan, like I said before, and even if an MRI shows a vestibular schwannoma, often we're still trying to treat the hearing loss that's present. Meaning if we can get the hearing better, then that gives the patient more time to have usable hearing on that ear. So it's not necessarily, for example, that once a patient has hearing loss, we would stop treatment. Rather, often we're continuing the treatment until that treatment is completed. This is especially useful for patients with vestibular schwannomas and sudden hearing loss, for whom we're recommending observation. basically no active treatment, because then we want the patients, of course, to use their hearing as long as possible. Moving on to the second symptom I had mentioned, dizziness. It's common in patients who have been diagnosed with vestibular schwannomas in the sense that if you ask these patients, oh, have you had dizziness, say within the past year or 2 or 5 years, they'll often say, oh yeah, I had, a couple episodes here or there, or, there's a period of time when I was quite dizzy. But rarely is dizziness the primary complaint. Rarely do patients come in with dizziness and then we diagnose a vestibular schwannoma. The reason for dizziness, as you can imagine, is because the tumor cells, which are arising from the vestibular nerve, are slowly invading the normal nerve fiber cells. And then so this leads to, in most patients, a very slow compensation or adaptation of that vestibular loss on the side of the tumor. And as we know from our training, because the compensation happens so gradually, patients often are not acutely vertiginous. Sure, some patients are, but a lot of the time, or most of the time, if you will, they're not. That being said, if a patient comes in and they have significant dizziness, we'll likely be treating their dizziness as their, presenting complaint. And so I've listed on the bottom of the slide several medications. Some are over the counter, some are prescription, that we would use to treat dizziness in the acute setting. When I see a patient with vertigo, I don't routinely obtain an MRI scan because the hit rate, if you will, is relatively low. So relatively few patients who come in with acute vertigo will end up having a vestibular schwannoma on their scan. Dizziness can happen, as you can imagine, for a variety of other reasons, and there are many other diagnoses that can cause dizziness. But if a patient is coming in even with a labyrinthitis, for example, a sudden hearing loss plus dizziness, we'll often be reaching for some of these medications. One thing that's a little confusing is there's two different types of Dramamine that are marketed. So one's meclizine and one's dimenhydrinate. And the meclizine, depending on whom you ask, meclizine might be a little bit gentler, but these medications generally all cause some sort of lethargy as a side effect. So they make patients sleepy. But they can be very important for patients that are acutely vertiginous and need some medication. We're going to move on to the trigeminal symptoms. The trigeminal nerve, again, is one of those cranial nerves on the slide that I showed earlier, the paired nerves coming out of the brainstem. And the trigeminal nerve actually provides sensation to the head and the face. And so on this diagram, the trigeminal nerve has three branches: the ophthalmic, which is the top branch, the maxillary, which is the middle branch, the pink, and the mandibular, which is the yellow branch. And these are the areas that each of those branches of the trigeminal nerve are providing sensation to. Because vestibular schwannomas, if they're large enough, can push on the trigeminal nerve, patients may have some sort of tingling on their face, or paresthesias as we call it, or they might even have decreased sensation or numbness. And again, this is rarely the primary complaint, but actually it's pretty common if you're asking all patients whom you've diagnosed with vestibular schwannomas whether or not they have some sort of facial numbness. Rarely, it can mimic trigeminal neuralgia, which is a more serious and more painful condition than simply paresthesias or numbness. But that doesn't happen very often. And the numbness can happen to any branch or any combination of branches of the trigeminal nerve, depending on how the tumor is compressing it. This diagram also nicely shows how the trigeminal nerve basically only controls sensation to the front part of the scalp and the face. And then there are other nerves that come from the cervical nerves, the cervical spine, that control sensation to a lot of the other areas of the head and neck. If patients are very symptomatic, we'll be prescribing medications such as, for example, gabapentin, that can help a lot with paresthesias or numbness. And trigeminal symptoms actually often get better after surgery, after the tumor is basically the pressure of the tumor on the trigeminal nerve is resolved. After we take the tumor off of the trigeminal nerve, often trigeminal symptoms will get better. This is another scan of what hydrocephalus might look like. Again, colloquially, we call it water on the brain. And when the tumor is blocking the normal circulation of cerebrospinal fluid, then there usually is either an excess in production or a delay in reabsorption. And that causes water to build up on the brain slowly. One of the main complaints in patients with hydrocephalus is they'll have headaches, they may have nausea, and then when it's really severe, they can have visual disturbance too. Balance issues have been reported, especially with other types of hydrocephalus, but patients with vestibular schwannomas may already have pre-existing balance issues just from the vestibular schwannoma and the vestibular nerve itself. And our body actually produces a lot of CSF every day, so about 500 milliliters. And as you can imagine, it's a closed loop system, so that's all constantly getting reabsorbed by our bodies. Fortunately, with modern medicine, hydrocephalus is quite rare in terms of vestibular schwannoma presentation, meaning often patients are having other symptoms and we're diagnosing a vestibular schwannoma before it gets to crisis mode and patients are presenting with hydrocephalus. But as you can imagine, maybe back in the day, we're talking a couple hundred years ago, that wasn't the case, and hydrocephalus was a major cause of morbidity and mortality. And nowadays in modern medicine, it's super easy to obtain a CT scan or MRI scan, definitely in an emergency room. And even if you're seeing a patient in clinic, it's easy to send a patient for a scan. It's, I would say, less common when we see patients with vestibular schwannomas. Depending on what the exact cause of the hydrocephalus is and how long it sticks around, sometimes the treatment is getting rid of the tumor, or we enlist the help of the neurosurgeons to help us resolve the hydrocephalus separately. And that can involve various procedures or medications. So I want to talk a little bit about the facial nerve. Many of you may already know the individuals on the slide. This is Dr. John House, who's at our clinic, the House Clinic, and Dr. Daryl Brackman. And in 1985, Dr. House and Dr. Brackman published their paper concerning how to grade facial nerve function. It's the most cited paper in otolaryngology. As of 2 days ago, it was at 5,191 citations, and that number keeps going up. And in this paper, they proposed a 1 to 6 scale, which is used widely for grading facial nerve function. Grade 1 is considered normal, and grade 6 is the worst facial function that's possible, which is no movement whatsoever when the patient is trying to move their face. And there are various levels between 1 and 6 of progressively worse facial function. Between 3 and 4, the main cutoff is whether or not a patient has complete eye closure on the affected side that we're talking about. And so we'd be grading the facial nerve function on one side versus the other. And a patient, theoretically, any patient will have two facial nerve functions, one on one side, one on the other. In 3, patients are able to close their eyes. And in 4, patients are not able to close their eyes. And it's very useful for tracking facial nerve function before and after surgery. Most of the patients whom we're diagnosing initially with vestibular schwannomas have facial function 1 out of 6, because most patients do not have any facial dysfunction from the tumor pushing on the facial nerve. Again, the facial nerve is very robust, and so most patients are not having any facial paralysis at the time of presentation. But occasionally, again, patients might be coming in with some subtle facial twitching or some subtle paralysis or a delay in how fast their eye blinks on the affected side. And that can be another symptom. So I'm going to talk a little bit about MRI scans and diagnosis, and then talk about different modalities that we also use besides an MRI scan. So an MRI is the gold standard for diagnosing vestibular schwannomas. Many of you may know that we used to obtain ABRs, but because MRIs are so commonplace now compared to, say, 20, 30 years ago, MRIs are the gold standard for diagnosis. When do we recommend an MRI? If patients have sudden sensorineural hearing loss, we'll typically always order an MRI scan. If a patient is coming to us for hearing loss and they have a difference of 15 decibels at 2 frequencies or 10 decibels at 2 contiguous frequencies, we might be considering ordering an MRI scan at that time also. The exact cutoff is actually open to debate, and depending on which paper you read, patients or authors have different criteria: 20 decibels across 4 frequencies, 15 across 3, for example, or some other combination thereof of when we order an MRI scan. But suffice it to say, if the symptoms are sufficiently unilateral or asymmetric, we should be ordering an MRI scan. If you've had an MRI, they typically take a long time. They're way longer than a CT scan, and they're extremely loud. There have been studies that are written about how loud an MRI scan is, and depending on which study you're reading, the scan can be, as the scanner itself, while it's doing the scan, can be as loud as 130 decibels, which is why, as you know, if for anyone that's had an MRI, when you go to the MRI center, they have a bowl of earplugs sitting there for patients. So I always tell patients if they're getting an MRI scan, make sure you wear the earplugs that they're giving you. The type of scan that we obtain is called an MRI of the brain and IC with and without contrast. So that looks not only at the whole brain, but it also looks at the internal auditory canals. Again, the pipes in which the hearing and vestibulocochlear, the hearing and the facial nerves are traveling, so we can see if there's any abnormalities there. Often for these MRI scans, patients will have a head coil. So a head coil is this additional device that basically enhances the picture of the scan. And for patients that are claustrophobic, some pre-medication is often given. We're talking about things like Valium or Ativan, some oral medication that the patient can take maybe 15 minutes or so before their scan, so they can finish the scan without moving. So this is what a scan of a vestibular schwannoma might look like, another scan. So this one is a T1 with contrast scan. And with contrast means the patient has already received the intravenous injection of contrast dye, the gadolinium dye typically. And you see a small area of brightness within the internal auditory canal on the right side of the patient, left side of the picture here. If we're looking at a T2 scan, we can often see the vestibulocochlear and facial nerves in relief relative to the cerebrospinal fluid. This patient has a left-sided tumor. It's very cystic. And on the right side, you can see the little stripes of the vestibulocochlear and the facial nerves. And so you can actually see a really nicely defined picture with these heavily T2 weighted sequences. Sometimes in medical terms, depending on the scanner brand that is it's being done in, it's called a Fiesta or a KISS, CISS sequence. And it gives you these very nice pictures of the nerves in relief relative to the CSF, which is white. And again, this patient has a very cystic vestibular schwannoma on the left side. We used to use ABRs to screen for vestibular schwannomas, as I mentioned earlier. And telltale signs on ABR can, of course, if there's an absent response, that might clue you into the fact that there's something retrocochlear going on. If you have an interoral wave 5 latency greater than 0.2 milliseconds, that can be another clue. And then I've listed other measures that people have studied, which many of you are familiar with, of different cutoffs and criteria for when we're detecting some sort of retrocochlear pathology. We know that ABRs aren't super sensitive, so there can be false negatives, especially if we have small tumors which aren't affecting the hearing or the cochlear nerve enough. We might actually get a normal ABR reading. Many years ago now, so this is back in the 60s, several researchers came up with a stacked ABR. And I realize many of you know this better than me, so please apologize. Please bear with me as I'm trying to explain this. But when we do a stacked ABR, basically, my understanding is you all are using masking to test different frequencies within the cochlea, and then with the computer system, you're aligning it typically with a wave 5 peak, and then you're adding all the results together. And that can theoretically increase the sensitivity of detecting for retrocochlear pathology. I think ABRs in clinical practice from the physician's point of view are very useful for detecting non-organic hearing loss, detecting hearing loss in patients who are unable to undergo subjective behavioral audiometry. So that includes many children. But we actually use it a lot less nowadays for the diagnosis of vestibular schwannomas. CT scan can be used in patients to look for vestibular schwannomas if the patients can't undergo an MRI scan. And I've listed some common reasons for why patients might not be able to have an MRI. Pacemaker is a big one. Metal implants somewhere in their body, or, for example, combat veterans with metal fragments in their body. The CT scans are a lot worse than MRI scans for looking at soft tissue, and that includes brain tissue, nerves, and tumors. And so you can see on this scan, even though this is a soft tissue window, so it's actually supposed to be optimized for looking at soft tissues and tumors, you can barely make out the structure of the brainstem and the cerebellum and the cerebrum in this photo. So CT scans we basically reserve for patients that really can't undergo an MRI scan. And the tumors really have to be large enough for us to detect it. Either the internal auditory canal bone has been pushed out because of the tumor, or the tumor really is so large that we can see it in the soft tissue windows on a CT scan. We're going to talk a little bit about NF2 since we're talking about the diagnosis. And we mentioned briefly how NF2 or neurofibromatosis type 2, the hallmark of it is when patients have bilateral vestibular schwannomas, one or more on each side. If it's inherited, then it's inherited in an autosomal dominant fashion, meaning if you have one parent that's affected, then the offspring has a 50-50 chance of getting the gene that's mutated. But about half of the cases of patients with NF2 are de novo, so there's no previous family history of having these vestibular schwannomas in bilateral fashion. And the incidence overall of this is pretty rare, 1 per 30 to 60,000 people, depending on whom you ask. The diagnostic criteria for NF2 have changed over the years. I've listed a paper citing the newest criteria from 2022, as well as some of the old criteria. But essentially, if a patient has bilateral vestibular schwannomas, they have NF2. If somebody has a combination of a vestibular schwannoma only on one side and some other types of tumors or findings, or a first-degree relative NF2, then presumptively they also have NF2. And depending on which paper you're reading or which consensus you're following, again, there are different intricacies to how we diagnose NF2 definitively. Just a quick note about treatment of NF2 related vestibular schwannomas, because when I delve into the treatment in a few slides, we're going to be talking mostly about patients that are the more common type, which is just one vestibular schwannoma, a sporadic, if you will, vestibular schwannoma. So for NF2 patients, typically we're monitoring the vestibular schwannomas until the tumors are large enough for us to worry about or causing other issues, and then we'd be considering surgical resection. When we're doing surgical resection, we're often considering using an auditory brainstem implant because the cochlear nerve typically cannot be saved in vestibular schwannoma surgeries, especially when the tumors are so large, which is often the case for NF2 patients. There are also medical treatments for NF2 and NF2 tumors, and those include various chemotherapeutic agents that are aimed at slowing down the growth of the tumor. The auditory brainstem implant was conceived by William House in the 1970s at the House Ear Institute. And in 1979, William House and the neurosurgeon who was working with the House clinic at that time, William Pitzelberger, implanted the first ABI. The device actually moved, and a couple of years later, they actually placed another implant. She was having, I think, some leg symptoms from the implant. And she was very happy with the implant, and she kept on seeing us. And I even saw her in clinic once. She kept on seeing us until she unfortunately passed away in 2018. So the very first ABI recipient. And this is sort of an evolution of the different types of electrodes that were developed over the course of coming up with the ABI. In 2000, the multi-channel ABIs were approved by the FDA. And the current indication is for patients that are age 12 or older who have NF2, typically who are undergoing surgery for removing the vestibular schwannoma. That's when the ABI would be placed at the same time while everything's open. And in 2016, my understanding is that the FDA approved an updated device. There are various centers around the world that are using ABIs for congenital hearing loss in patients with absent cochlear nerves. That includes, of course, patients with labyrinthine malformations, inner ear malformations, patients who can't undergo a cochlear implant for whatever reason. That's actually less commonly done in the United States, but I think that's a new frontier of ABIs, in addition to the uses that we have for NF2. So let's talk about the treatment of sporadic vestibular schwannomas. And again, these are the garden variety vestibular schwannomas where patients come in with a hearing loss and we find out that they have a vestibular schwannoma. We can do surgery, and surgery is broken down into hearing preservation and non-hearing preservation types. We can do radiation, the majority of which is now stereotactic radiation. And then we can also observe the tumor, meaning we're not doing anything active for treatment, rather just waiting to see if the tumor is going to grow. So when do we do surgery for tumors? Well, if the tumor is large, so typically that's greater than 2 or 2.5 centimeters, so an inch or larger, and those patients need surgery to prevent other issues, um, including things like hydrocephalus, including mass effect on the brain. If a patient has severe dizziness, surgery can actually be curative for the dizziness. The thought is if the tumor cells are affecting the vestibular nerve fibers, the yet unaffected or the vestibular nerve fibers that are starting to get eaten up by the tumor enough, patients might have a lot of dizziness. So if we resect the tumor and snip the ends of the vestibular nerve, then patients might long-term have less dizziness. So that's another indication for surgery. And if a patient has severe to profound hearing loss, then that can actually be another reason to do surgery, because the thought would be, well, the hearing's not good already. Let's just go in and take it out once and for all, so we're not worrying about this tumor long term causing other issues as it continues to grow. If we have a small tumor or an older patient, say age 70, 75 and above, we might be considering either observation or radiation. So in the late 1890s, that was the first time there was a documented attempt to remove vestibular schwannoma. Granted, this may have happened without documentation even before this, but this is Dr. von Bergmann from Germany, and the patient died on the table secondary to hemorrhage because, as you can imagine, we're talking 130 years ago, things were a lot less sophisticated then. Sir Charles Ballance in 1894 proposed a suboccipital approach to remove a vestibular schwannoma. Based on his description, there's some uncertainty whether he was talking about a vestibular schwannoma or a meningioma, which, like I said on one of the previous slides, is sort of the second most common tumor that we find in that area. And intraoperatively, he found that the tumor was very adherent to the dura, the lining of the brain. But he was able to complete that surgery. And then Dr. Annandale in Scotland described another surgery where he removed a tumor from a retrosigmoid or suboccipital approach, so behind the ear and below the ear. And the tumor was about the size of a pigeon's egg. And so that was almost certainly a vestibular schwannoma. Dr. Panzer from Germany in 1904 proposed a translabyrinthine approach, which involved chiseling out the mastoid and removing the inner ear structures. We know now that translabyrinthine approaches are routine for removing vestibular schwannomas, but he was widely criticized when he proposed it because it seemed too aggressive or too destructive. And Dr. Quicks in 1911 removed a tumor via the same approach that Dr. Panza had discussed. Dr. Cushing at Johns Hopkins in the US is considered the father of modern neurosurgery, and he wrote a paper called Tumors of the Nervus Acousticus and Syndrome of the Cerebello-Pontine Angle. And he talked about using a bilateral suboccipital approach to remove these tumors. And the mortality was about 20%, which surprisingly, back in those days, was actually not too bad. So he was quite respected for this and, of course, for his many other contributions to neurology and neurosurgery. Walter Dandy was one of Dr. Cushing's proteges, and he talked about a two-stage procedure for removing vestibular schwannomas, first debulking the tumor and then excising the capsule. His mortality was a little bit higher than Dr. Cushing's, but his approach was a unilateral approach, so only on one side, on the side of the tumor. Fast forward a few years, and Dr. Cairns, who practiced in the UK but was from Australia, talked about resecting a vestibular schwannoma, and he was actually the first documented surgeon documented to have removed a vestibular schwannoma with facial nerve function preserved. And so the patient had facial weakness postoperatively, but that actually improved. So he at least preserved some, if not all, of the facial nerve fibers. Interestingly, he also advocated for the use of motorcycle helmets, and that's one of his lasting legacies. Around the same time, in the 1920s and 1950s, surgeons in Germany started using microscopes. Howard House, who founded our clinic, he was the half brother of William House, and he was older than William House. And he actually imported, to I believe our knowledge, the first operating microscope from Germany to Los Angeles. And in 1956, William House started using the microscope for middle ear surgery because he realized that you can see so much better when you're using the microscope to do surgery rather than using loupes mounted on glasses, which was the standard procedure in the US before then. And Dr. Kurtz in 1957 at USC then saw Dr. House operating and Dr. William House operating and then decided to try removing a vestibular schwannoma with the microscope. Dr. William House did a whole bunch of other things. We talked about him conceiving and developing the ABI. He took the translabyrinthine approach which Dr. Panza had described over 50 years prior, and he sort of resurrected it to resect vestibular schwannomas. He also used it for other pathologies. And then he also talked about the middle fossa approach and basically developed the middle fossa approach, which we do all the time now for resection of vestibular schwannomas. And this is another photo of him with a patient here. Breaking down the various types of surgeries that we do for vestibular schwannomas, the primary non-hearing preservation approach is the translabyrinthine approach. And as many of you know, after we do a translabyrinthine approach, patients have a resultant profound sensorineural hearing loss from the disruption of the endolymphatic and perilymphatic structures. Even though we're not drilling through the cochlea, we're only drilling through the labyrinth of the vestibule and the semicircular canals. Patients, again, typically have a profound hearing loss after surgery. The hearing preservation approaches are the middle fossa approach and the retrosigmoid, which, as I mentioned on previous slides, is occasionally termed the suboccipital approach. And those approaches are approaches where we're not destroying the otic capsule and where patients may still be able to hear postoperatively. Unfortunately, the hearing is typically not better than it was before surgery, but there is a possibility of maintaining the old hearing level after one of the bottom two approaches. If the tumor is large or the hearing is already poor, or both, we're often electing to use a translabyrinthine approach. If the tumor is smaller and the hearing is still serviceable, then we might be choosing a retrosigmoid or a middle fossa approach. Depending on the configuration of the tumor, we might be choosing one of those two approaches too, even in a non-hearing preservation case where we know the patient's hearing is already bad and we know that we can't try to preserve it or it'd be very difficult. We might consider one of the other two approaches too, but often we're going for the translabyrinthine approach. Those of you that have been in an OR know that surgery is a team effort. There's a lot of people in the operating room. At our clinic, we have fellows, so there's one of us, there's a fellow, there's a neurosurgeon, there's the neurophysiologist, who sometimes has an audiologic degree for facial nerve monitoring, and then all of the operating room staff, the anesthesiologist, the scrub tech, the nurses, and sometimes there are doubles of those individuals. So there are a lot of people all working on the same patient. The intraop neurophysiology that we're testing during surgery and monitoring primarily includes the facial nerve. And then so we're doing a continuous, basically EMG of the facial nerve while we're working on the tumor. And we're basically seeing if we're evoking any EMG responses through any either mechanical irritation of the facial nerve or if we're using the stimulator through electrical stimulation of the facial nerve. For hearing preservation cases, we're performing an ABR at the same time, and so the ABR apparatus is all hooked up before the patient is draped and prepared for surgery after the patient's asleep. And in select cases, we might be obtaining some somatosensory evoked potentials, monitoring those during surgery. Depending on the case, we might be monitoring other other cranial nerves also. If we put an electrode in the masseter muscle on the side of the face, we might be monitoring cranial nerve 5, which is the trigeminal nerve. And then if we're putting an electrode in the soft palate, then we can use that to monitor the ninth cranial nerve or the glossopharyngeal nerve. And then if we want to monitor the 10th cranial nerve, then we'll use a laryngeal EMG endotracheal tube. So when the vocal cords are being stimulated by the vagus nerve, we'll get a response from the monitor also. But these are less common for patients with ordinary vestibular schwannomas. We might consider one of these other electrodes for patients with large tumors, but typically we're doing facial nerve plus or minus the hearing nerve monitoring. When we're doing a translabyrinthine approach, again, we're drilling through the bony labyrinth. We're drilling through the vestibule and the semicircular canals. Typically, we're not drilling through the cochlea. Sometimes we do a transotic or a transcochlear approach, and we would be drilling through the cochlea, but most vestibular schwannomas can be removed without us drilling through the cochlea. So we're drilling all the structures of the inner ear, basically posterior to the cochlea, which again is the vestibule and the semicircular canals. This is the patient positioning, so they're lying down on the operating room table, their head is turned away from us, and we're exposing basically the skull bone posterior to the ear canal and drilling out this area. The advantages of a translabyrinthine approach are it gives us a great view. The cerebellum or hindbrain doesn't need to be significantly retracted, and we can pack the eustachian tube directly. And when I say pack, we're literally putting pieces of sterile bone wax within the eustachian tube to make sure that the cerebrospinal fluid doesn't flow out through the eustachian tube and into the nose, because if it does, that could increase the chance of meningitis. And so a translabyrinthine approach has a lower risk of CSF leak, arguably, because of that. As you can imagine, one of the main disadvantages is patients have a profound hearing loss after surgery. This is of course all done under general anesthesia, so patients are totally asleep. Again, patients are lying on their back with their head turned. And we usually monitor other things. We're monitoring urine output during surgery with the Foley. We're monitoring blood pressure very closely with an arterial line. Uh, I talked about packing the eustachian tube to basically prevent CSF from flowing in that direction. We also use abdominal fat after the tumor has been removed to pack the area of bone that has been removed. So again, this sort of wedge-shaped bone on our way in gets packed with abdominal fat. And we use a titanium plate on the outside of that to hold everything in place. That actually keeps the fat pushing on the area where the CSF is, where the dura is, and it prevents the CSF from coming out. And the plate also restores the normal contour of the side of the head, so there's not a big divot there. And once again, with a translabyrinthine approach, typically patients can't hear afterwards. There have been select case reports of patients still having some hearing after a translab, but it's quite rare. For a retrosigmoid approach, patients are also lying down, but their head is actually put in a Mayfield apparatus. That's the way that we do it. I know many other centers also do it that way too. And this actually pins the head in rigid fixation. And so we're able to position the head just so before we do a retrosigmoid approach. And the primary reason for that is because the patient needs to be turned just a little bit over compared to the translabyrinthine approach. And the Mayfield gives us very solid fixation of the head that way. But similarly, we're monitoring a whole bunch of things during surgery, just like with the translabyrinthine approach. One of the advantages of a retrosigmoid approach is familiarity to the neurosurgeon. This is an approach that they would use when they're doing other procedures, not involving us for a variety of other conditions. And the bone that's removed is farther back than a translabyrinthine approach, which is where my pointer is here. The retrosigmoid bone is farther posterior. And so this chunk of bone would be removed, and we'd be basically going in through this area to get to the tumor. It's also relatively fast when we're considering when the surgery starts to when the neurosurgeon starts removing the tumor. But there are disadvantages. We can't access tumors at the fundus or the end of the internal auditory canal. The angle isn't favorable for that. And because we're making an incision farther back, it actually is really close to the neck muscles. And so patients have a greater chance of having a post-op headache with a retrosigmoid approach than with a translab approach. Finally, the last approach is the middle fossa approach. Often we're making a question mark or reverse question mark incision. We're sitting at the top of the patient's head. The patient is lying down on the bed and their head is turned. And we're making this sort of question mark or reverse question mark incision. And then once we get in to the side of the skull, then we're drilling out additional bone to uncover the internal auditory canal. This is suitable for small tumors because we only get a small little view, but it's a great view of the internal auditory canal itself. And similarly to the other approaches, we're also monitoring a lot of things during surgery. The incision is typically totally within the hairline. Patients often ask, is the hair going to grow back? And the answer is yes. Even though there's an incision there, the hair follicles are still present. So the hair is going to grow back there. And we restore the contour of the skull by putting that square of bone back and screwing it to the side of the skull again. So patients have the normal flatness of the side of their skull after surgery. This is the House Urban Retractor, which we use for middle fossa surgeries. It's a special retractor, which is a modified version of a self-retaining retractor with a special blade that we're able to insert into the retractor and basically hold the brain, the temporal lobe, out of place as we're doing the drilling. Again, middle fossa approach is perfect for small tumors, and we can get all the way to the end or the fundus of the internal auditory canal with that exposure. But one of the disadvantages is we're actually pushing on the temporal bone for a long time, usually for a couple of hours while we're doing the drilling. And from the moment we start surgery to when the neurosurgeon is starting to work, that actually can be a good 3-4 hours. Patients have to be a really good candidate for a middle fossa approach. We typically don't do it if the patient is over 65 years of age, although there are certain exceptions. And typically we're saving it for patients with serviceable hearing because we're trying to save the hearing. And the tumor, again, has to be small enough. I have a couple of intra-op photos from surgery. So this is what the middle fossa approach would look like with the retractor in place. And then here we're starting to drill, and we're basically drilling the bone of the middle fossa floor, uncovering the internal auditory canal. This is the facial nerve stimulator probe that we use. It's black and skinny, and it's got sort of a blunt, a very softly rounded end. And we're using it to stimulate the facial nerve and the greater superficial petrosal nerve, which is a branch of the facial nerve, for us to identify the facial nerve. And then once everything is done drilling, we have our cochlea, we have our superior semicircular canal and labyrinth, and we basically have the dura of the internal auditory canal all exposed, so the neurosurgeon can then go in and take out the tumor. And then when the neurosurgeon is taking out the tumor, this is what it might look like. The dura has been incised and flapped open, and we're basically removing this chunk, this fleshy tumor, from the rest of the nerves that are contained within the internal auditory canal. We often use the facial nerve stimulator during surgery. It helps us, again, identify the facial nerve location because we're doing an evoked EMG response by using current to stimulate the facial nerve. And it's actually pretty convenient for dissection because it's a nice length, it's nice and blunt, and it's able to help us tease tissue tumor away from facial nerve and other nerve tumor. The goal in hearing preservation surgery is to remove the tumor while preserving the cochlear nerve and the facial nerve. Um, between the two, the cochlear nerve and the facial nerve, patients are much more bothered by facial nerve dysfunction than they are with hearing dysfunction after surgery, interestingly enough. Things that patient asks about surgery, how long will it take? I tell patients average is about 8 hours. Sometimes the tumor comes out really easily. It's not super sticky. It comes out the facial nerve easily, so it might be less. Sometimes it can be longer, especially if the tumor is bigger. Patients have to be intubated for surgery because it's general anesthesia, but they can be extubated before they're even transferred to the ICU. So patients typically don't stay intubated in the ICU. And by the time they get up to the ICU, patients are usually pretty sleepy still from all the anesthesia medications, but they will respond to commands and they'll, in most cases, be oriented once they're awake enough to be answering questions. And then at the end of the tumor resection, we're taking an abdominal fat graft. I had alluded to this earlier. And it's surgeon dependent. I know there are certain centers that don't use abdominal fat grafts, but we use it for all three approaches, the translab, retrosigmoid, middle fossa. And the point of the abdominal fat graft is to plug openings in the dura to avoid CSF from leaking out. And because it's the body's own tissue, the body doesn't reject it and it works really well. And the fat actually stays in place indefinitely. Some of it gets reabsorbed, but you can actually see it on an MRI scan after surgery. So that's the first half of my talk, maybe a little bit just beyond the halfway point. I'm cognizant of the time, it being 11:10. Uh, I think that what we should do is maybe we'll collect some questions in the comments if anyone has any questions, and then we'll take like just a 1 or 2 minute break, and then I can come back, answer the questions, and then go over the remainder of my talk just for a couple minutes. So if you have any questions, please put it in the chat. Are there any questions from anyone in the audience? If not,
Oh, we got a whole slew of questions. It
oh my
depends.
gosh,
It
I only
depends.
see one thing in the chat right now.
It depends on, well, I've got them in the questions here. It depends on when you
Ah, I
want to
see.
answer questions.
Okay. Um,
Up to you.
I'll do the question in the chat real fast. Is there a time after so many days or weeks when steroid treatment is deemed not beneficial for sudden hearing loss? It depends on which paper you're reading. Some papers will say a cutoff of 6 weeks. Other papers are more generous and say it's even longer. So I always discuss the risks and benefits to the patient and basically determine whether or not they want to start therapy. Fortunately, I think because it's such a big issue for patients, they're coming in within the first several weeks, maybe with authorizations, might add a couple weeks there. So we're almost always within the 6 week mark. But sure, if it's been like 8 months, 9 months since the onset of hearing loss, we often um, will not be offering steroid therapy. That makes sense.
Someone I know
Turning his
was
Zoom around.
diagnosed with Meniere's and had an MRI to rule out vestibular schwannoma. The MRI was done only without contrast. Could this miss a tumor?
Yes, it can. Typically, for patients with Meniere's disease, we're ordering MRI scans because those patients will have a unilateral hearing loss, and we definitely want to rule out a tumor.
And so
About
would you
every
do that
couple of
without
years
without contrast or with
with
contrast?
contrast. So definitely we need one with contrast.
And you're using gadolinium.
Yes, exactly.
Um, Cochlear implant companies say that people with their implants can undergo MRIs with up to 3 Teslas
Yes.
without removing the magnet. What do the most current MRI machines use in terms of Teslas?
Usually about 3 Tesla. That's the most common scanners out there. Sometimes they're 1.5, which is of course even easier, but most are 3.
So then they don't need to remove the magnet.
Right.
Okay. What does the latest research show about patients' word recognition with an ABI?
Yeah.
Do they only get sound awareness?
I think most patients with ABIs, NF2 patients with ABIs, are using ABIs to augment lip reading. And many patients rely on ABIs mostly for sound awareness. Occasionally, there are patients that are hearing great speech with an ABI, but I think it's because cochlear implants work so well when we're comparing CIs to ABIs, the tonotopic organization of the cochlea makes it so that CIs are much higher fidelity,
Right,
which is why ABIs are sort of a secondary uh, option, but often the only option for patients with NF2.
right. Um, Back to the beginning of the presentation, is anyone doing a study to determine best steroid protocols?
Yes, there have been various studies that have been written about the best steroid protocols. I think that the difficulty is there's a lot of heterogeneity in patients coming in, both in terms of the degree of hearing loss, the time that has elapsed, other factors. And because of that, it's really difficult to pin down what is the best for any random patient walking into the clinic with a sudden hearing loss. So the way that the American Academy of Otolaryngology puts it is basically just describing, steroids at a high dosage, close to 1 milligram per kilogram, and 60 is often the number that we sort of round it off at as what we're using for treating it.
Right. Um, why are ENTs afraid to order neuro ABRs? Wait a minute, I lost this one.
And then go straight to MRI, which is more
Right,
expensive. I think that is probably true. The cost of MRIs is going down. And the cost of ABRs definitely includes not only the apparatus and as well as the audiologist's time. And ABRs, depending on who's doing it, I suppose, can take as long as or even longer than an MRI scan. The main reason, though, I believe, is because it's less sensitive. Because
right,
even if we find an abnormality on the ABR, then we want to get an MRI anyway to see what exactly is going on. And so
sure.
often we're just sort of leapfrogging, going straight to the MRI.
Have you noticed the age of neuroma patients trending to younger ages? It seems like we have a large group, 20 to 42 years old, with large neuromas over the past several years.
Yes, and I think that's increased awareness both among uh, internal medicine or family medicine physicians, increasing awareness among ENTs, even though that gets sort of beaten to us even when we're in training, and just the increasing availability of MRI scans. And I think that that is just bringing the diagnosis earlier and earlier, both in terms of course of disease as well as earlier in stage of life.
I think you mentioned this during the talk, but at what age do acoustic schwannomas most commonly begin to appear?
About 50 to 60 is the most common. 50 to 60 years of age is the most common age group.
Um, can you provide a link for discussion on time frame to give steroids for sensory neural hearing loss?
Yes, I can definitely find one. I think I'd have to Google offline. I'll have my contact information. Betty, if you wouldn't mind emailing me afterwards, and then I can reply to your email. Um, I'll have my contact information on my concluding slides. That way I won't forget.
And would steroid treatments only work on certain causes of hearing loss?
Of course, typically we're giving it for patients with sudden sensorineural hearing loss. Interestingly, sometimes patients present with otosclerosis with a sudden hearing loss, meaning there's something about their foot plate that fixes all of a sudden. And interestingly, sometimes that actually gets better when we give them a little bit of steroids, but we know the natural history of otosclerosis is progressive hardening of the foot plate and the annular ligament around the oval window. The short answer to that is pretty much we're treating sudden sensory hearing loss related to some sort of nerve phenomenon, either the cochlear nerve or the inner ear hair cell issue. But maybe steroids work for other causes too.
You know that I did a lot of monitoring when I was there
Hmm.
for about 6, 7 years. Monitored 1,000 tumors.
Yeah,
Um,
right.
and we did middle fossa approach for a hearing preservation approach. And what I found attempting to do ABR to monitor the cochlear nerve during those procedures, it's extremely time consuming
Hmm.
because you're in an electrically hostile environment, and it's very difficult to get a good tracing in time to make any adjustment in your surgical approach.
Exactly.
So what I began doing was a direct nerve monitoring,
That's
where I
right.
actually constructed a small electrode that they would place right down on the cochlear nerve
Right.
while they were dissecting the tumor. And
Right.
I found that to be very time sensitive.
Yeah. That's a great answer. And Dr. Cueva in San Diego, who I believe is well, I don't know if he's retired or retiring. He had an eponymous Cueva electrode, which we would put on the cochlear nerve.
Right.
I agree that works great. The downsides are we have to expose the tumor already by the time we're down there, and then so all the time
Right.
before that we're going in blind. And then the electrode itself is a little finicky. Like you have to put it there, and then make sure when you're manipulating that you're not moving the electrode itself.
Yeah, it's
But
sometimes you have to remove
absolutely,
it and replace it and remove it and replace it.
right.
Dr. Hitzelberger, when I was working with him, he used to, when we would start to get an effect on the direct nerve monitoring, he'd use some papaverine to
Hmm.
increase blood supply. I don't know if
Right.
that ever did any good.
Yeah, that's right, and that's been described, and I think the jury's still out. We're not sure, but I think that's still a common thing to do. And then, do we still use acoustic reflex thresholds and reflex decay to screen for AN? Um, I think physicians order it less. I think there are probably some physicians that are ordering it and the audiologists that are performing it. But we're screening mostly with an MRI scan, screening and diagnosing with an MRI scan, just because that's so readily available.
Okay, I think that's
Great.
all.
So I'll
Oh, I
hop in.
wanted to ask one more question really quickly.
Yeah.
We know that these tumors are typically benign or always benign.
Okay.
Um, do you go back and rescan ever?
Ye- Depending on if we resect the tumor, then almost always we're getting follow-up scans. And if we're observing, then the patients are on a schedule of every year, scans every year or every couple of years. So typically, yeah, I mean, we're just constantly monitoring. So
So even after you've removed the tumor,
yeah,
you do still go back and do another MRI a couple of years
that's right.
down the line.
That's right.
Interesting. Okay.
And then last question before we move on, is it possible to perform the implant, which we'll talk about briefly, at the same time as tumor removal? Yes. And if we're doing an NF2 surgery, often we're doing ABI at the same time. If we're doing a cochlear implant, that needs to be discussed with the patient and also cleared with insurance before the surgery. And that's actually hard. That's probably one of the biggest hurdles, basically getting insurance approval for a CI to be done simultaneously. Um,
Right.
but indeed, very occasionally we do that. If the cochlea is preserved, ossification typically happens within the first 6 months, if it's going to happen, which is why we typically want to get the implant in sort of around the 6 month mark. So indeed, that's a consideration. I don't know. I think that might be one of the areas where acoustic neuroma surgery is going to evolve, where we're doing CIs simultaneously with cochlear with tumor removal more frequently. But right now, I think logistically there are more hurdles.
Okay. Good enough.
Great.
Thank
So
you so much. Go ahead
yeah.
and
So
proceed.
Moving on to just a few of the risks of surgery, because patients also like to ask this, and I think it's good for us to know. Um, Pain, infection, bleeding that can happen with any sort of surgery. We talked about CSF leak, which is the spinal fluid leaking out of an area we don't want it to leak out of the nose, out of the incision, and that needs to be addressed. Very, very rarely do we have patients with strokes or, heaven forbid, patients passing away from surgery. The chances of those are extremely low. So even though it's brain surgery with a neurosurgeon there resecting the tumor as we're going in, the risk of stroke or death is extraordinarily low. Pain is pretty easy to treat because there are so many different pain medications at our disposal, both while the patient is in the hospital as well as when the patient goes home. These tumors typically are not super bloody compared to some other tumors that we deal with, such as glomus tumors. And these patients typically will have a moderate blood loss because the surgery does take, a long time. It takes hours and hours. It's very unlikely to require a transfusion for vestibular schwannoma surgery. That being said, we're always asking patients for their permission to give them a transfusion should it be necessary. Infections are also quite uncommon, and infections can be infections of the skin, the surgical site there, or it can be meningitis. Part of the reason that infections are so uncommon is we're giving prophylactic antibiotics. So we're giving antibiotics that are going into the patient's system before the incision is made, and we're re-giving a dose during surgery if the surgery is taking long enough. Most head and neck surgical procedures are considered overall a low infection risk. CSF leak is serious. The vast majority of CSF leaks occur while patients are in the hospital, so we discover it then. Patients will be telling the nurse or telling us when we're rounding, hey, my nose is dripping and it's clear fluid. And this needs to be addressed when it's discovered. Depending on the site of the leak, there are various things we can do. If it's coming from the incision, we might suture the incision. If it's coming from the nose, we might put in a lumbar drain so that the CSF then drains through the lumbar area, the spinal tap area, instead of leaking out through the nose, for example, and letting whatever opening in the dura is up there to seal off. And sometimes we have to go back in and do surgery again to close off the leak. And the main reason we're worried about CSF leaks is because it increases the risk of meningitis, which itself can be life-threatening. This is a photo of facial nerve paresis or paralysis. You might hear these terms used variably. So palsy, often we use to refer to any sort of paresis or paralysis. And in the ENT world, we're often using the word paralysis to mean total paralysis, meaning the face doesn't move. House Brackman, grade 6 out of 6. Whereas paresis might be a partial paralysis. The neurologists have a different perspective on these terms, and they use the terms perhaps slightly differently, but this is at least what we typically do in the ENT world. To try to prevent this, as well as to treat it if it happens, we're giving patients steroids and antivirals after surgery. The antivirals and steroids are even continued after patients leave the hospital. And we give it routinely, even if patients wake up and they don't have any facial paralysis, because the thought is that if we can get these medications on board and minimize the risk of swelling to the facial nerve, patients will overall have less of a chance of getting some sort of facial paralysis or palsy. And if there is some impairment of facial function, we're often giving a even longer course of these oral medications. Dry eye and taste disturbance are two actually fairly common side effects that I think are underappreciated. And the reason for that is there is a small nerve called the nervus intermedius, which is right next to the facial nerve and the vestibulocochlear nerve. It actually ends up joining up with the facial nerve, but because it's so small and next to the tumor, it's often sacrificed when we remove the tumor. Patients can notice decreased tearing on that side. They might notice a impairment of the taste on that side of their tongue only, and the symptoms can be temporary or permanent. If they are permanent, then we basically treat the eye as it needs to be treated with whatever ophthalmology is recommending. And the taste, that depends, but I think many patients, quite frankly, end up getting used to that long-term deficit. The surgical stay is usually in the ICU for one night, and then on the regular floor for a couple of nights thereafter. And once patients are well enough to start participating in therapy, then the physical and occupational therapists are helping patients walk, transfer from the bed to the commode, go to the bathroom, use the bathroom. And patients leave the hospital in a few days, and typically after about a couple weeks, or maybe even up to 3, 4 weeks, patients are pretty much all back to normal and independent, and that would include driving in most cases, if the patient can drive before, of course. Very roughly, I think the chance of removing all the tumor cells is pretty high, probably 80–90%. The chance of preserving hearing for hearing preservation cases, meaning not translabyrinthine approach, the chance of hearing preservation is actually lower. So I often tell patients, look, it's going to be about a 50–50 chance of us doing a hearing preservation case to see whether or not your hearing is still going to be working afterwards. The reason for that is because the cochlear nerve itself is very delicate, much more delicate than the facial nerve. And even if we tug on it the wrong way, that can cause the cochlear nerve not to work well. The long-term rates of recurrence of the tumor or tumor regrowth are low, probably between 5 and 10%, but it can even happen years and years after the original surgery is performed, which is why we're obtaining post-op MRIs on patients after tumor surgery. The long-term facial nerve preservation rate is quite high, probably 90–95%, meaning the vast majority of patients undergoing vestibular schwannoma surgery don't have long-term facial nerve issues. We're typically obtaining an MRI scan after surgery on the first day after surgery. We obtain another scan 3 to 6 months after that. We obtain another scan a year after that, or a year after surgery. And then about every year thereafter, we're obtaining another follow-up scan to make sure the tumor isn't growing back. Depending on the patient, the tumor, the physician, we might be getting scans every couple of years, for example. And for hearing preservation cases, typically I want to be checking the hearing about 6 weeks after surgery because a lot of things can happen within that first 6 weeks. When we're doing surgery, there's irrigation fluid everywhere. That gets in the middle ear, it stays in the mastoid. There's bleeding, even after we've stopped the bleeding, there's some blood that's oozing into all those areas. And all that fluid needs to be reabsorbed so we can get a good idea of what the patient's hearing might be after surgery. And so I usually wait about 6 weeks after surgery to test the hearing. Switching gears, talking about radiation, which is another treatment option for vestibular schwannomas. You might hear it called stereotactic radiation or radiosurgery. There are various types of radiation machines or modalities that are available. CyberKnife and Gamma Knife are very common, and LINAC and proton beam are newer. And IMRT is sort of tried and true. Depending on the center, that's often less used for vestibular schwannomas. We know that radiation can damage the hearing long term, and there are papers that have investigated what happens to hearing following radiation for vestibular schwannomas. And depending on whom you ask, surgery probably has a slightly higher rate of hearing preservation. In other words, if the tumor is a great candidate for surgery, great candidate for hearing preservation surgery, and we are able to take the tumor out and save the hearing, often that leads to a more durable long-term hearing result than doing radiation. Radiation has a very low risk of secondary malignancy, meaning other tumors that are happening because the radiation was done. That usually happens in the tract of the radiation. But radiation still remains a great option, for example, for patients that are elderly but the tumors are growing, or other patients that, say, can't have surgery for some reason or another. Side effects of radiation include the tumor continuing to grow. If the tumor continues to grow after radiation, surgery is definitely harder the second time around. There's a chance of hydrocephalus, water on the brain just from the radiation itself. Rarely there's a chance of facial nerve paresis or paralysis. So in that sense, radiation beats out surgery. There's a much lower risk of paresis or paralysis of the facial nerve. And we talked about hearing loss, where radiation itself is associated with long-term hearing loss. Radiation has an easier recovery than surgery. Apologies for the typo. Because there's typically no hospital stay. Radiation might occur over the course of 1 or a few days. Patients are going home as long as there are no immediate complications. And then finally, another way that we have of managing these tumors is just watching and waiting, which we call observation. The advocates of observations, will mention that, up to a third of vestibular schwannomas just won't grow after diagnosis. And especially if a patient is elderly, we're not going to be recommending any major treatment. We would rather just watch and wait. I get a scan 6 months after diagnosis, and then I get scans every year thereafter for patients in whom we're watching and waiting. So in the last part of my talk, I'm going to talk about audiological rehabilitation of patients who have undergone treatment for vestibular schwannomas. For patients in whom hearing is preserved after surgery, and the hearing is serviceable, we're often considering some sort of hearing amplification, as you can imagine. For patients in whom we preserve the hearing but it's not serviceable, like the word recognition unfortunately is quite poor after surgery, for example, but they still hear, then we might be considering a cochlear implant for these patients. If the hearing is not preserved from surgery, say they underwent a translabyrinthine approach, or they underwent a middle fossa approach but the hearing wasn't preserved, then we're basically in either the SSD category or in some patients in the asymmetric hearing loss category. And we might be considering a cochlear implant if the cochlear nerve itself is intact. We'll talk about ways that we have of assessing for that. If the cochlear nerve itself is not intact, then we're often using a cross or a bicross device, depending on the situation with the other ear, a bone conduction implant, and we talked already about an ABI for patients with NF2, because that's the FDA approval. The ABI for patients with NF2 if the cochlear nerve itself is not intact after surgery. When we're assessing hearing serviceability after surgery, we're often using the AAO hearing classification, and that's broken down into A, B, C, D. D is the category where word recognition scores are 50% or worse. And then serviceable hearing is mostly Class A or Class B hearing, or sometimes Class C hearing, depending on whom you're asking, meaning the word discrimination is better than 50%. And A, of course, is the best, where patients are in the great category of great word recognition and a very low pure tone average. If it's a home run and patients have Class A hearing before surgery and that's preserved after surgery, then a hearing aid might be all they need or nothing. Typically, we're using 50% as the cutoff for serviceability. Some patients, granted, with word recognition scores under 50%, will still like using a hearing aid because it gives them some sound awareness and helps them localize sound if they're able to use just volume cues. And other patients will try a hearing aid when their word recognition is less than 50% and absolutely hate it. So it can be very patient dependent. If we try to preserve hearing, but the hearing unfortunately doesn't get preserved after, then we might be talking to the patient about assessing the integrity of their cochlear nerve after they've healed. So we're talking about a month or two after surgery. We want to see if the cochlear nerve can still conduct electrical signals. And the test that we like to use is the promontory stimulation test. We're placing a transtympanic electrode on the promontory and asking the patient to report whether or not they have an auditory sensation when we're turning up the stimulus through that electrode. Many of you may be familiar with the fact that this used to be used to predict CI results. Promontory stimulation, was previously used to predict CI results in patients who are scheduled to undergo CI. But as we know, we rarely use it now for that purpose. Various other ways, modalities can be used to try to assess the integrity of the cochlear nerve. Some centers only do an ABR test, which I think is reasonable also. But we sort of stick with the promontory stimulation test. If the cochlear nerve seems to be intact on the prom stim test and the hearing unfortunately is poor, then we're talking about a cochlear implant. Usually I would perform this probably about 6 months postoperatively. Well, no, later than that, because the cochlea can ossify, as we talked about, but not necessarily sooner, because we want to make sure the hearing stabilizes before the patient undergoes surgery. The performance after a CI in tumor patients can vary a lot. It depends on a whole lot of things, on the exact integrity of the nerve, the cochlear nerve, after the tumor has been removed, on how the cochlea is after the patient has had hearing preservation surgery. So I think there are a lot of variables there. For patients in whom we're planning on doing a CI after vestibular schwannoma surgery, getting an MRI scan is essential. First of all, we have to make sure that there's no tumor recurrence or residual that we're worried about that we want to be monitoring for. And we also want to make sure there's still fluid signal within the cochlea, that there's no early ossification of the cochlea so that we can actually be able to put in the implant. These patients are often getting a streptococcus pneumonia vaccine before the cochlear implant, which, as you know, is very routine for any patient undergoing a cochlear implant because that also prevents against meningitis. For some reason, patients with cochlear implants have a higher risk of getting meningitis just from the fact that the cochlea itself is opened. And one of the reasons we make sure we get an MRI scan before we put in a cochlear implant is because there is a large magnet shadow on the MRI scan. So even though even though the cochlear implants from the three companies are MRI compatible, they still will produce a large shadow. And if this is in the area of the tumor bed where the tumor was removed, it becomes very difficult to look for residual tumor. So we want to make sure we get an MRI scan before we put in the cochlear implant with the magnet. There's the option of leaving the magnet out of the device, so we remove the magnet from its little silicone slot, but that leads to much more difficult use by the patient because putting the processor on with the magnet is so convenient. For patients with NF2, we're often leaving the magnet out because we know they need lifelong MRIs. But for patients with vestibular schwannomas who undergo a CI afterwards, often we're leaving the magnet in and having the patient use a cochlear implant in the conventional fashion with the processor attached via the magnet. If the hearing is not preserved and the cochlear nerve is not intact, then of course we're talking about some sort of cross system or perhaps a bone conduction system. I think the biggest factor that goes into this is patient preference. Some patients don't want any more surgeries because the vestibular schwannoma surgery was a big deal and they're not feeling like having any other surgeries. And other patients are totally okay with going through another minor surgical procedure to get an implant. The benefits of a cross device are it's pretty fast to get fitted with a cross device and start using it versus bone conduction devices where we have to plan surgery, do the surgery, have a brief waiting period in most cases, and then use the device only thereafter. If patients are using cross or bicross, typically there's not a whole lot of meaningful sound localization, but if you ask patients, some patients use the auditory clues coming into their better ear as well as coming out of the device on their better ear to try to divine which side sounds are coming in from. And so some patients, even though we think traditionally, oh, a cross, bicross, or even a bone conduction, that shouldn't significantly help with sound localization. Some patients still are able to use that information. So this can be a great option for patients after a vestibular schwannoma surgery with hearing loss who don't want any further surgery. This is not a comprehensive list, but it's a list of the devices that I feel I use the most in clinical practice. There are definitely some devices that I haven't mentioned that aren't on this list. But when we're talking about bone connection devices, we're basically breaking it up into two big categories: the implantable category and the ones that don't require surgery or an implant. And so many of you are already familiar with the Ossia, the Bone Bridge, and the Sentio, the older options, the Baja and the Ponto. And in terms of the non-implantable options, there are various types of soft bands as well as headbands, and then the Medel Adhere. The caveat to all this is that the better hearing ear must meet the fitting criteria of the specific device or implant that is chosen. The majority of the ones that we use for adults after tumor surgery are implantable, because if patients don't want an implantable device, often they're going straight for the cross or bicross. A bone conduction was actually conceived many, many years ago, and an Italian physician reported that a rod placed between a patient's teeth could actually transmit sounds to the ear, and that was back in 1550. In 1933, a device with an actuator on the mastoid with a headband was developed, and in the 1950s, bone conduction devices were fixed onto glasses temples, and that's sort of making a resurgence over the past couple of years. In the 1950s, Dr. Brennemark in Sweden developed the use of dental implants, which are osseointegrated on bone, fused to bone, given a certain amount of time after surgery. And that was huge because dental implants now are mainstream. And then in 1977, Dr. Kjellstrom, also in Sweden, basically decided to use that technology to try to incorporate it into a percutaneous device with that implant technology osseointegrating into bone. And that's what evolved into the cochlear Baha. And this is a photo of Dr. Kjellstrom with one of the devices. When we're talking about these bone conduction implants, we talk about percutaneous versus transcutaneous. Percutaneous means through and through the scalp, and transcutaneous means a magnetic connection. If we have a magnetic connection, there's usually a magnet shadow that is blocking the surgical field, similar to a cochlear implant. If the bone has already been removed from surgery, either via retrosigmoid, translab, middle fossa approach, that actually impacts where we can put the implant on, because if the bone's missing, we can't be screwing the implant onto that area. So often for these bone conduction devices for patients that have had vestibular schwannoma surgery, we're adjusting the position of the implant slightly so that we can actually get it onto the skull and affixed. And usually that involves putting it either more posterior or more superior compared to a patient that hasn't had tumor surgery. The tried and true options are the cochlear Baha and the Oticon Ponto. Those are osseointegrated into the bone, and that's percutaneous, so it sticks out of the scalp. There's little to no MRI shadow based on these devices, but one of the downsides is patients can often have a long-term infection or cellulitis there. Patients might say it's constantly weepy, like they can still wear their implant, but it's constantly weepy and has been for even years. The surgical procedure for these is relatively fast, 30 minutes or even less. And again, it's tried and true and easily performed if that's what a patient decides. The Ossia was approved in or around 2019. It's made by Cochlear. The implant itself is the same as the Baha implant. And so we put that in first, but the abutment isn't there. So instead of screwing the abutment on, as many of you know, when we're doing surgery, the abutment is usually screwed to the implant when we're doing a Baha surgery. But for the Ossia, we're putting the implant separately, screwing it in, and then screwing on the silicone device onto that implant. And I usually have patients wait about 4 weeks prior to activation of getting the outside part and starting to use it. It's been updated since its release. The Medal Bone Bridge is another device. It was approved in or around 2018, and it's also been updated since that time. When I put in these implants, I have to drill a well for the can of the implant, if you will, which is this part here. And it's all involved within sort of a silicone casing, and then so up here, the silicone case that is again still under the scalp. And then it's affixed with a couple of screws, and patients can use that device. I also wait typically about 4 weeks after surgery, just because I want to make sure all the swelling is gone and the site isn't sensitive anymore before patients start using it. And then the newest one on the market is the Oticon Sentio. There's a small well that needs to be drilled similar to a bone bridge. There's a little strap that gets screwed onto the skull that holds the implant in place. And similarly, of course, there's an outside magnetic processor. I like to time the surgery of these implants, usually about, again, 6 months after resection of the tumor. It depends a lot on the patient whether or not they end up liking these implants. I have some patients that use these implants daily and have been using for years and years, and other patients who come back to me maybe even just a year or two after I've put in the implant after their tumor surgery, and they say, look, I really don't like it. Can you please take it out? Sometimes that's because of infectious reasons. Other times it's because patients don't feel like it helps a lot. And it's totally acceptable for a patient to say, hey, I don't want anything else. You took out the tumor. I'm just going to live with hearing out of my other ear. I think that's a totally reasonable option, depending on if, what the patient chooses. So just a few takeaway points. Their vestibular schwannomas are slow-growing tumors. They're benign. We talked about observation, radiation, and surgery as options for management. Depending on the type of surgery and the type of tumor, we might be picking surgery for large tumors or younger patients. If patients are older, we'll be choosing observation or maybe radiation. And typically the outcomes are quite good with surgery and with radiation also, in addition to all the other stuff we covered in the talk, of course. I have a couple of how to contact us slides. This is the first one. And I'm going to scroll over to the Q&A if any of you want to be jotting down this information before I go on to the next slide. So let me take a look here. So two of the questions that I see here from Kathy. Do patients who have tumors removed using the retrosigmoid approach have headaches long term, or do they subside given enough time? Unfortunately, with the retrosigmoid approach, that approach has the most long-term postoperative headache of any of the three surgical approaches. There are unfortunately patients that state they have headaches years after surgery, and we start getting creative with how we manage that, either with musculoskeletal interventions, with neurologists helping us manage it, etc. So it can be both, but unfortunately, some are long-term. How does one use a cochlear implant without a magnet? There are actually little sticker discs, magnet discs, which the implant companies sell. And the hair is shaved right over the implant. The sticker disc, the magnet, is affixed to that area of shaved scalp. And then the outside processor basically sticks onto that little sticker disc just magnetically. And patients, especially NF2 patients, are super used to it, where they're doing the shaving and then putting on the disc that stays there for a week. They take it off, they shave it again, and then they stick on the new sticker disc, and then they use the implant that way. I refreshed the slide to the other our other contact information if any of you need to contact us or have patients contact us. Can cell phone use or wireless Bluetooth earbuds increase the risk of getting vestibular schwannomas? There was a controversial paper written years ago that suggested that that was the case, but the prevailing thought now is that no, because the radiation that we get from cell phones is non-ionizing radiation. Typically, it doesn't increase the risk of getting any benign tumors nor any malignant tumors. So I think that's the answer that you'll get from most physicians if you ask them. And who does mostly facial monitoring? Uh, and I maybe the person who typed this can answer in terms of who are you asking? Who in terms of the surgeons or in terms of who perhaps audiologists gravitate toward these versus cochlear monitoring during surgery. Facial nerve monitoring is 100% all surgeries under for vestibular schwannomas, and most if not all mastoid surgeries we're doing facial nerve monitoring. And then I think the extra is basically doing some sort of cochlear or auditory monitoring for patients in whom we're concerned about the hearing intraoperatively, namely those where we're trying to preserve hearing. So facial nerve monitoring happens for all surgeries. Any diet restrictions for those diagnosed with vestibular schwannomas? Not really. Ironically, because our center, we are so used to doing abdominal fat grafts, we think it greatly decreases the CSF leak rate. And I realize that's not necessarily a universal thing because there are centers that are performing vestibular schwannoma surgeries without using fat grafts as much. Ironically, because of that, one of our former internal medicine physicians would tell patients to eat a lot of ice cream before surgery to make sure that they have enough abdominal fat so that we can get a big enough fat graft to make sure that the CSF leak is plugged up. So no specific diet restrictions to my knowledge. So we just have a few minutes left. If there are any parting questions, please type them.
No open questions that I can see.
Great.
I just like to thank you, Dr. Peng. That was a wonderful discussion, very informative. I think everybody took away some very interesting information. Um, I understand that tonight, Dr. House and Dr. Brackman are being honored is that the Institute?
Yeah, we actually have it's actually we have a small event going on. We had the House Backman Gala, but that's actually been postponed till next year. So there's a
Oh,
small event for the institute that they're putting it on tonight. But for anyone that's interested, please contact us. Join our House Institute Foundation mailing list. If you just search House Ear Institute or House Institute Foundation, you'll find our website. Join the mailing list, and yeah, we look forward to connecting more with you all.
would you please congratulate both of them for me?
Yeah, will do. Thanks.
Okay. Thank you so much again for your talk and your time today. We really appreciate it.
Yeah, thank you.
Bye
Okay.
bye.